Hello everyone, my name is Serge Klin and I'm a resident from Lviv Regional Clinical Hospital, Ukraine. First of all, I would like to thank for the opportunity to present our work on Enoxaparin management of moderately severe acute pancreatitis. I have no disclosure. Acute pancreatitis is a big problem in modern world. Mortality in patients with severe acute pancreatitis reaches 30%. Pathogenesis of acute pancreatitis is very difficult, and for that reason, there is no pathogenesis treatment for this disease. Standard treatment includes infusion therapy, painkillers, and symptoms therapy. It's well known that acute pancreatitis is followed by a hypercoagulation state. That's why it makes sense to add anticoagulant to the treatment. Good candidate for that is enoxaparin. That has numerous anti-inflammatory effects. It blocks pro-inflammatory chemokine-mediated hemotaxis, activation of T cells, chemokine-mediated adhesion and transmigration. So the aim of our study was to investigate an effect of enoxaparin in patients with moderately severe acute pancreatitis. For that, we took 98 patients and divided them for two groups. The first group became standard treatment of plus enoxaparin 1 milligram per kilogram once a day for 12 days, and a control group 63 patients with just a standard treatment. As you can see, the checkpoints were the first day, third day, seventh day, and the 14th day. We measured some pro-inflammatory cytokines and CRP, and also done collagram and the dimer. So as you can see, collagram normalized faster in the group with enoxaparin, and but the biggest progression was in the group like with a dimer. In the group with enoxaparin, it's constantly decreased, but in the group without anticoagulant, it's just increased. What about the level of pro-inflammatory cytokines and CRP? Their levels also decreased much faster in the group with enoxaparin. Levels of interleukin 6 and CRP on day 14 in the group with anticoagulant was twice lower than in the group without it. For the evaluation of clinical status, we used Apache 2 score, and in the group with enoxaparin, it decreased much faster than in the group without it. In the group with enoxaparin, mortality was almost 3%, but without it, almost 8%. 30% of patients without enoxaparin needed open necrosectomy, and just 11% of the patients in the enoxaparin group. So in conclusion, I would like to say that enoxaparin improves outcomes in patients with moderately severe acute pancreatitis. Enoxaparin implication reduced inflammation process and coagulation state, improved the condition of patients, reduced their morbidity level. Of course, our study was very small and not randomized, but we hope that it encourage another researcher for future investigation in this field and do some big placebo control multi-center randomized trial. So thank you for your attention, and have a good time on this conference.